Shalom to everyone around the world and Happy New Year. Today's webinar, which features three of our most prominent corona specialists, is designed to dispel the rumors, the disinformation, and the fog surrounding the corona pandemic, as well as Sheba's heroic efforts to make Israel the first nation in the world to emerge from the horrible situation with its rapid vacation program. At less than a year, we have miraculously gone from delighting with the silent enemy that pushed our staff to the limits to offering hope without boundaries to the citizen of Israel and the world. Thank you for tuning in. I will now turn the webinar over to Steve Walst, the Director of International Media Relations and the spokesman of Sheba Medical Center. Steve, the stage is yours.
Thank you, Yoel, and good evening, morning, and afternoon to everyone. And of course, a Happy New Year. At least we can hope that it will be better this year. At Sheba, we are pursuing that light at the end of the dark corona tunnel, engaging in a rapid vaccination process that has made Israel #1 in the world in vaccinating its people, while at the same time, we are combating a vicious, and I mean a vicious, third corona wave. So today I have the distinct pleasure of hosting this webinar with three of our most renowned corona doctors who have been on the front lines of battling this insidious pandemic since last February. Professor Galia Rahav, Dr. Gili Regev Yochai, and Professor Ayal Leshem. All three have appeared on Israeli television almost every single week. All three have garnered media coverage on an international scale. So tonight's format of this webinar will be as follows. Each of our three doctors will give about a 10-minute presentation regarding the latest corona issues. They have seen many of the questions that have been submitted in advance, and they will attempt to address many of those main issues within the context of the time that they have been given. And then afterwards, as time permits, I will ask them questions as well that have come from all around the world. So let's kick things off with Professor Galia Rahav. Galia?
Okay, good evening. So I'd like to start with Tom Frieden, who was the former head of the CDC, and he gave a lecture only 2 months ago at a virtual infectious disease convention, the ID Week, and he said, we are not going back to the old normal. The world will be BC and DC before COVID and during COVID. I don't think we see an AC after COVID anytime soon. I hope that he's wrong with this part of his talk. However, he said also that there is still a tremendous amount we don't know about COVID. Let's be clear about what we know, how we know it, and how we are trying to find it out. And I agree so much with this part of his talk. So during the last year, we have tried so many things to control the pandemic. However, in less than a year, more than 85 million cases we have in the world, more than 1.8 million deaths. There is severe disruption of health system due to COVID and non-COVID case conditions. There is severe economic crisis. And as you can understand, the only way really to kill or to fight the COVID-19 is really vaccination. 70% or more of the population must be immune in order to stop community transmission. And remember, vaccines will not work if people will not take them. Immunization is the most important intervention in medicine. Only vaccines stop smallpox, polio, tetanus, and many other diseases. I cannot understand those who say It is an unsafe vaccine, as it took only 10 months to develop the vaccine instead of the traditional 10 to 15 years. However, there is progress in medicine and in science. It took only 7 days to discover the virus that caused the disease. And if we go back to the AIDS pandemic, if you remember, it took about 2 to 3 years to find that HIV cause HIV. Second, there was fantastic collaboration between industry, science, and governments. Governments put millions or billions in vaccine development. And third, high number of patients makes it easy to perform a study and to recruit volunteers. And finally, there was no cutting off regulation. There was cutting off of bureaucracy. So please don't say, I got my COVID-19 vaccine and look what happened to me. Say on each day that we don't vaccinated, more than 10,000 die from COVID-19. The spike protein of the virus or its receptor binding domain is responsible to binding the virus to our cells, to the ACE2 receptors. And all the vaccines are really developed against this spike protein. The FDA published principles how COVID vaccine study should be done. Randomized control study, minimum of 30,000 volunteers. The study population should be diverse in age, in underlying disease, race, male and female. The primary endpoint should be prevention of symptomatic disease, and the primary efficacy endpoint should be the vaccine should be 50% efficacious or more. Now, nowadays, there are more than 200 vaccine candidates, more than 60 vaccines in human trials. One vaccine was abandoned, the Australian vaccine, as it caused false positive with HIV results. And 2 or even 3 were approved, the Moderna and the Pfizer. However, the Astrozonica last weekend was approved in the UK. Now we have mainly four platforms of vaccine. The nucleic acid vaccine, DNA and RNA, the viral vector vaccines, those who are with replicating virus and non-replicating virus, protein-based vaccine, protein subunit and virus-like particles, and viral vaccines, inactivated vaccine and live attenuated vaccines. Now, these are the leading vaccines, the mRNA vaccines, the adenovirus vaccines, protein vaccines, and inactivated vaccines that I want to talk about them, mainly from China and used in China, and the Sinopharm and the Sinovac vaccines. So let's go to the mRNA vaccines. What is mRNA vaccine? Scientists in the lab prepare DNA that encode to the spike protein. Then in the lab, they add enzymes, nucleotide buffer, and then the DNA is transcribed to the messenger RNA. It is impossible to use this mRNA as a vaccine, as it is immediately destroyed by enzymes in our body. So recently, lipid nanoparticles were produced to keep the mRNA intact, and this is the vaccine. mRNA with the lipid nanoparticle envelope. After injection, the vaccine, the lipid nanoparticle deliver the vaccine to the antigen-presenting cells, which are part of the immune system in our body. And here in the cytoplasm of the cell, not in the nucleus, the mRNA produce spike proteins in the cell ribosomes. Then the spike protein and its product are presented to the immune cells, the T cells, the lymphocyte, and the B cells to produce immune response. mRNA does not enter to the nucleus. There is no shift of RNA to DNA, and RNA is rapidly degraded to all the people who are afraid from RNA vaccines. mRNA was discovered a long time ago, 1961. And the concept of mRNA vaccines, as you can see here, was developed in the 1990s. And since then, there was quite a lot of work on mRNA vaccines in cancer and in virology. There are many advantages to the mRNA vaccines. Easy to produce, very safe because there is no live virus, very immunogenic, no need for adjuvant, easy to change if we have mutation, the DNA that I showed you before, it's very easy to change it. The only disadvantage is that it's a new technology. We have two mRNA vaccines, the Pfizer and BioNTech, 2 dosage, 21 days apart. And the RNA is the full spike protein. And the NIH Moderna vaccine, 2 doses, 28 days apart, and also full length of the protein. And let's start with the Pfizer vaccine. The Pfizer vaccine, a lot of non-clinical study, and we can see here the toxicological study that were done in rats, and they were completed with no safety concern. And there is also pharmacology study that were checked in monkeys, and it was found to protect against the virus. Phase 1 study, usually it's done to show the safety of the vaccine, and the phase 1 study of Pfizer showed that there were mild, local, and systemic side effects. The side effects were higher after the second dose and in young adults. Neutralizing antibody, as you can see here, the titers was similar in young people and in old people. And very interestingly, when we compare the neutralizing antibody to people who recovered from corona, you see that the titer in those who were vaccinated are higher than among those who were recovered from the disease. Now, it's very important because you hear nowadays that in England and also in Israel, people or scientists or physicians suggest to vaccinate with only 1 dose of the vaccine. And you can see here that a neutralizing antibody develop only after day 28. After 3 weeks, not enough neutralizing antibody. So this, I think, an answer to a very important question. Now let's move to the phase 3 study of Pfizer. The study population were adults, healthy or with stable chronic medical conditions. The exclusion criteria were history of COVID-19, immunosuppressed patient or pregnant woman, and the people were randomized, as I told you before. Now, the study included about 40,000 cases. Half got the vaccine and half got the placebo. The female and male distribution were equal. The median age was 51. You can see here that 42% of people were older than 55 years. About half of the patient had comorbidity, 35% were obese, and the distribution was equal between 2 groups. The vaccine efficacy, 7 days post the second vaccine, was 95%, and we can see here that the efficacy was the same in all age group, in male and female, in people with underlying disease and without underlying disease. we can see here that you can see here in red the efficacy or the number of COVID-19 and people who got the vaccine, and here in blue the number of COVID-19 in people who got the placebo, and you'll see that there is really early protection by the vaccine starting as soon as 12 days. So it's really remarkable. What about side effects? Side effects develop in about 27% of people who got the vaccine and 12% of people who got the placebo. 4 patients in the vaccine group develop a serious adverse event. 6 die, 2 in the vaccine group and 4 in the placebo group. None were related to the vaccine. 70% of patients who got the vaccine developed local pain. The other side effects were not remarkable. Systemic events, mainly fever, were reported more often in young. Young, it's in blue, and older, it's in green. So they were reported the side effects, mainly the fever, higher rates in young recipients and more often after the second dose. All the other, excuse me, I just want to ask you, there are a lot of questions that we have about the vaccines. First of all, will we expect safety issue to arise when big numbers, millions or billions of people will be vaccinated? Will side effects emerge with longer follow-up? How long will the vaccine be effective? We don't know. Does the vaccine prevent asymptomatic disease, which limit transmission? We don't know yet. The number of severe cases of COVID-19 in the study was too small to draw any conclusion, so we need to have more patients, more volunteers to study it more. What happened to recipients who miss 1 dose? We don't know. What about the group of people who were not represented in this study, for example, children, pregnant women, immune-suppressed patients? What about all the logistic challenges, keeping it in the minus 70 degree? And what about ethical problems? You know, we have to follow up. The patient in the placebo group should be followed up for 2 years. Should we vaccinate these people with a very effective vaccine nowadays? Now we had very practical question. What about pregnant and lactating women? So, you know, in UK, they don't vaccinate them. In US, they decided to vaccinate them. And nobody knows because they were not included in the study. We decided in Israel not to push them to be vaccinated. However, if we have a high-risk patient, for example, a nurse that works with patient, and she knows that nothing was, we don't have any data, and she really decides that she wants the vaccine, we will vaccinate her. We vaccinate most patients with immune-suppressed disease, autoimmune disease, allergy, and we decided not to vaccinate people who had already COVID-19. So all the other vaccine, I'll really speak very, very briefly. The Mrna vaccine, a very nice study with non-human primate, a very nice study, phase 1 study. Now I'll move to the Cove Study, the phase 3 study, 3,000 volunteers, a very nice representation of diverse age and the comorbidities, and the efficacy was 94%, 96% efficacy in young people, and 86% efficacy in those 65 years or more. And the same plot you can see here that was presented with the Pfizer vaccine. Now, Moderna announced that the vaccine may be effective against transmission, but we have to see all the data. And the side effects are similar to the Pfizer vaccine. 3 people developed Bell's palsy, and it's paralysis of the facial nerve, 2 in the vaccine group and 1 in the placebo, and there was no anaphylactic reaction. The viral vector vaccines contain viruses that are engineered to carry coronavirus genes. some vectors enter cells and cause them, the human cells, to make viral proteins. Other viral vectors replicate and carry coronavirus proteins on their surface. As you see here, there are several COVID vector vaccines. Those who do not replicate it in the host are mainly the Astrozonica, the vector is adenovirus of chimpanzee. The Chinese vaccine, the CanSino, with adenovirus, human adenovirus. The Sputnik 5, which is 2 adenovirus vaccine, the Janssen vaccine, and more. And the replicating viral vector are the Merck measles vaccine and the Israeli vaccine that I'll speak shortly. Now, about the AstraZeneca vaccine, I'll just present the phase 3 study. You can see here the 2 doses of the vaccine were 62% efficacy. When they gave half of the dose in the first time, and then the second dose was a full dose, they found 90% efficacy. However, the dose version was a result of mistake, and those who got this half dose were 55 years old or less. So what was decided is that AstraZeneca will repeat the study, and they decided to do it together with the Sputnik vaccine. However, last week in the UK, AstraZeneca vaccine was approved, and also I heard today that also in India they are going to vaccinate with AstraZeneca vaccine. The Sputnik vaccine, the Russian vaccine, also 2 adenoviruses. However, there is no animal data. The phase 1 and 2 study were open study, not randomized, only males. It looks a good vaccine. However, not according to the FDA rules. And the phase 3 study, RESIST study, included 4,000 cases, and the efficacy was 92%. However, they had only 20 infection, which are not enough, you know, very low numbers. The Israeli vaccine, we call it the BRILife, that was developed by the Israel Institute for Biological Research. It is a slow replicating vesicular stomatitis virus of cows. They changed the G gene of the VSV genome with spike gene of the coronavirus. And I can tell you that this platform was the platform that was done to Ebola virus, Ebola vaccine. And they did quite remarkable work in animal models, 4 animal models they had. And at Sheba Medical Center and also in Hadassah, we conducted the phase 1 study that was successfully finished and without any significant side effects. And now we are beginning the phase 2 study. So vector vaccines are non-technology, they are safe. However, the disadvantage, if, for example, we use adenovirus, human adenovirus, there is previous exposure to the carrier, and maybe there will be some interference with the immunological outcome. And the last are the protein-based vaccines that contain coronavirus proteins, but no genetics material. Some vaccines contain whole proteins, some fragments of the proteins, and some pack many of the molecules or nanoparticles, such as this vaccine, the Novavax vaccine, with the very active matrix M adjuvant. The problems with these vaccines are that they are very complicated to produce. So my last slide is that, yes, the future is here. However, it takes time. And until we have all the vaccines available and all people are vaccinated, please don't forget to keep the commandment.
Okay, thank you very much, Dalia, for that extremely informative performance, as you say. It's you can't get more thorough than that. People who are not on, can you please go to mute, because we hear background noise. I'd like to introduce now Dr. Gili Regev Yochai. Gili?
Galia, can you stop sharing so I can share mine? Can everybody mute, please?
Mara, please
Everybody in mute, please.
Everybody can see?
Yep.
Yeah, and please, somebody's still not on mute. Okay, so I'll give a few minutes talking about a little bit more epidemiology and the roadmap to ending this pandemic. So if we're looking at where are we today, as Galia mentioned, we're in the third surge, probably also worldwide, with nearly 750,000 daily cases detected. And that's obviously not all of the true newly cases, just those that we actually detect. And with over 10,000 daily deaths. If we look at the situation in Israel, we are obviously in the third surge. The first one, although it was a very small one, there was a total lockdown. We were all very scared of what's happening. We understood it's a pandemic. The second one was pretty long, as we can see. It started somewhere in June, and then the actual surge was somewhere at the end of August. During this surge, we had about 2,000 death cases. And that leads us to where are we right now? It seems like this surge is going to be much worse, despite the issue of the vaccine. And that's, I think, where we are really in the race between how fast the vaccine will get versus how fast the virus moves along. So what determines how bad the pandemic will be? And I think there are actually three major factors that we need to understand. One is what we call the R, or the R naught, which I typically give between a lecture of 1 hour to a full course in epidemiology about what does this mean. Now I think every second grader knows to say what the R is, but I'll give a few words on it still. The second major variable that contributes to how bad a pandemic will be is, of course, how bad the actual disease is. How much is the case fatality rate or the mortality rate? How many people will actually die from the pandemic? And third is the infection control. How and which interventions we have and how effective are they? And I'll give a few words on each, and I think that will really make us understand why this is a pandemic, how bad is it, and how do we stop it. So first thing is the R, and when we talk about R, we typically are talking about what we all hear in the newspaper is the R effective, the actual R every day. But first of all, we have the R naught. The R naught is a fixed number, or relatively fixed at least, which is determined by how much contacts will be with a susceptible host within time, how long will the virus be around, and how well it is transmitted. And actually what it means is how many people will be infected by a person who comes into a fully susceptible population, meaning how many people will initially be infected by the first person coming into Israel, for example. And of course, it's not a single person, but the average. So if the 10 first people each infected on average about 4 people, the R naught will be 4, and so on. So the first 4 will then infect the next 4, and that will be already 16 people infected. And these 16, each one will infect on average another 4, and so on. And that's why it's exponential. And just to give you sort of the proportion, if we look at various infectious diseases, measles, which is one of the most contagious infections, has an R0 of about 10 to 13. Of course, it depends on how crowded is the population. It will not be the same when we're talking about the R0 of Manhattan versus the R0 of some more peripheral area. But anyway, we're talking about an average of measles, which is very highly contagious. And if we look at the COVID or SARS-CoV-2, we're talking about something between 2 to 4, some say even 5. I assume it's somewhere between the 3 to 4. And one of the worries is now that the British mutation, what we call the British mutation, might have a higher R0, meaning it is more transmittable. But when, and I think this graph here will show you what is the difference between the R0 and the R effective, the actual R. So if we talk on a pandemic, the initial step on a pandemic, and for this example, we're looking at an R0 with a 5, it means that the first person will infect these 5 people, and then the next person, and the early stage of the pandemic, that's exactly where we are. Each one will infect another 5, 25, and etc. It will increase exponentially. And what makes it then stop? It will get to the peak when each person can only infect one other person. Why can it only infect one other person? Because the other 3 that he meets are actually already immune. Why are they immune? Because they already got sick and now they have antibodies and they are immune. Then eventually we get to the end of the pandemic. And at the end of the pandemic, we see that most of the people are already immune. And that's why we're getting it low, and eventually maybe, just here and there, another person will get infected, but that's the end of that pandemic. Obviously, it's not as smooth as we see it in theory, but what happens, we'll see in a minute what happened in Israel or in the world. It doesn't really matter where we're looking at. And now one thing that we can actually understand from this is what is the proportion that we have to immunize if we want to eliminate an infection. And there's not a very complicated actual mathematical calculation. And it says that the proportion that needs to be vaccinated is 1 minus 1 over R0. So if we're talking about R0 of, let's say, 4, that would mean that we need to vaccinate 75% of the population. And that's exactly why the numbers that we're talking about are somewhere between 66% to maybe 80% of the population need to be vaccinated before we get over this pandemic. Again, if some of the people are already sick and they are immune naturally, that's also fine. But obviously we don't want to get there by only having people infected, because as you understand, it would mean that between 66 to 80% of the population would have to be already sick with COVID. And we know that the mortality, which I'll get to in a minute, is not that low. So I don't think we want to get there. We really want to get the vaccine getting us over this thing. So what is the difference between SARS that we had a few years ago, or decade ago, versus SARS-CoV-2 or the COVID? If we look at the R0, it's pretty similar. If we look at the mortality rates or the case fatality rate for SARS, it was much higher. So we would expect that SARS would have been a much worse pandemic, right? Because here we have somewhere between 1 to 2% mortality. And here we had nearly 11%. So why is SARS not such a big deal? We got over it relatively easily. Not too many people died altogether. And here with COVID, we have such a worldwide pandemic. And the explanation is the last thing that I mentioned, the effective infection control, which we had for SARS, but we don't have for COVID. And why is that? The explanation is here in this figure. And that is that when a person is infectious, okay, meaning that when he can transmit the infection is exactly the same time when he has a clinical disease. So you get exposed and then the virus starts incubating and eventually you start having the right amount of virus that you can infect your neighbor or your partner or your kids and etc. And at that time for SARS, it was exactly when you started having clinical symptoms, meaning fever, coughing, etc. Once you have fever, you are infectious. So it's very easy to control this. All you have to do is tell people that when they have fever, they stay at home. You put the fever and the thermometers in every airport, etc., and you stop the pandemic. You don't get into a pandemic. It's just an outbreak. The big problem here with COVID is that this is not exactly on the same time. We can have a very short time that the virus starts replicating. The person is infectious much before he has a clinical disease. It can be a day or two before, but the person might also be asymptomatic at all, never having any clinical disease, and still he is infectious. So, and that's exactly what's happening with kids at school. They go to school, they're not symptomatic, they start infecting all of their peers, and then the peers go home and start infecting the adults, and they might get a clinical disease, sometimes a bad disease, and sometimes even mortality. So the issue here is that we can't put thermometers and just stop the disease. We don't know how to detect these people unless we start really testing everybody, and that's obviously very difficult. And that exactly leads us to why the vaccine is actually the only measure that can really stop the pandemic. So how do we lower our effective? How do we break the chain? So one thing we do is put masks on. Other option is closing schools, and that way kids can transmit to each other. Obviously, we can isolate these high-risk elderly. Is it really realistic to isolate everybody who has high risk? It's probably not. We can identify symptomatic patients as we do with these thermometers, but as you understood, we can't identify that way the asymptomatic patients, positive patients. And that's why we maybe can do that by a lot of rapid testing, but again, it's not enough. How much of the population do we screen? How much can we do that? All of this is really difficult. And then we get to the lockdowns that none of us, I assume, like them. And I don't believe that they are the solution unless we want to live 2-3 years like this. So the only option is really the vaccine. And we can see that each time that we put a lockdown, then we stop the infection. Once we lift it, we start getting either slowly or sometimes more rapidly the next surge. So really the only solution to such a pandemic as this one is the vaccine. And now where are we heading? Okay, we're starting to give the vaccine here. What will be the next surge? Will it be something small? I guess we already know. When I prepared this, it was like a month ago. Now we know that it doesn't look like this. And it obviously looks much more like this. I hope it won't get this high, but I can tell you that this figure here is taken actually from Professor Eran Segal from the Weizmann Institute, who at that time, at the sometime middle December, which is only 3 weeks ago, said that with continuing having R effective of 1.15, and now it's actually even higher, it's 1.2 or more, and with vaccinating very successfully 1.5 million per month, I think we can do better if we have enough vaccines. Then the peak surge will be by mid-February, and we'll have about 12,000 newly detected cases. So that's not a very good picture that we want to look at. But I think, again, it depends on the rate of the vaccination coverage. How fast can we get that? If we do more than 1 million, and currently we have been doing 1 million within 2 weeks, if we continue like this, that's really, really very good. And the question is, who is the most important population that we want to vaccinate? If we do it on the general population, just aiming to get 66 to 80% of the population, that's a lot. Maybe if we vaccinate all of the population at risk, like we're aiming right now, we can actually stop at least the more severe disease. Maybe we don't stop the daily counts, but we can stop what's happening in the hospitals, and we can stop the mortality. Another question, maybe go to infectious populations, super spreaders. And with that, I think maybe we mean the schools, maybe we mean the airports, jails, etc. Maybe, first of all, put them as a first priority. And of course, there's a big question about pediatric vaccination. Where will we get over this pandemic if we don't vaccinate children? My assumption is probably not. I think we're still going to see COVID around as long as we don't vaccinate kids. But maybe we're going to get to a very different point and not, you know, a scary pandemic and not thinking of lockdowns, etc. So I agree with the current policy of, first of all, vaccinating the population at risk, but I think that we may need to eventually get to that pediatric population as well. So if we're thinking of back to normality, what is the roadmap? When will we get there? And I think we should look at 3 different levels. First, the personal level. What will I get out of getting vaccinated? Then what will my hospital get out of getting vaccinated? And then, of course, looking at the national level. So I think really with COVID, there are these 3 phases. And first of all, if we look at the personal level, finally, after 1 month, after we get both doses, then we will not need to be isolated after we get any exposure. The second thing is hopefully there's going to be a green passport for those who have the 2 vaccines, and they can again go and travel to red countries, come back, and they will not need to be vaccinated. Of course, we can then open culture, going maybe to the cinema, allowing that only for vaccinated people. If we look at the hospital level, the first thing that I'm looking forward to is once that we all have a month over having been vaccinated, we can eat together. Of course, only those people who have been vaccinated. One person who is not vaccinated will not enter that room. Maybe we can go back to meetings, conferences. And at the national level, of course, when will we get back to routine? When will we get the masks off? I think that will take a little bit more time, but I do think that we can go back to routine, even if it's a slightly different routine. It's a COVID routine with a lot of tests, with all those people getting vaccinated, and with this green card that will allow people into those places. So on the personal level, the first dose, at least for me, I've taken it 2 weeks ago. I can tell you that today, this morning, unfortunately, I still don't have antibodies. I looked around at some of the people that also tested, and some of them do have antibodies, but that's not a big surprise. We know that. That's why, as Galia mentioned, we need to wait longer. And after 28 days, I already see a lot of light at the end of the tunnel, and it's there. And I think it's really very exciting and very, I don't know, for me, it's more than, I don't know what superlative to use to say how excited I am with what I'm seeing happening in Israel, with us being really #1 in the vaccination. And I just hope that we continue like this, because maybe we can really go through this faster than other places. So I think we can stop this pandemic, but we just really need to get vaccinated. Thank you.
Gili, before I jump over to Ayal Leshem, there are a lot of questions about if you get vaccinated, and we're seeing this in Israel. We can answer this, and you can answer two for one. Does the British mutation have any impact? And two, if you do get vaccinated, can you still infect people?
Those are two big questions. First of all, the British mutation right now, we have all the suggestions that there will be no, the vaccine is good and effective for it. The final answer, we're still waiting. It will take a little longer, but we'll have that answer. It seems right now that there's no problem and and the vaccine is probably effective against the British mutation. I think the more worrisome issue is that if we have these mutations, it means that we may get mutations also for the vaccine eventually. And I think that sort of leads us to think that there is a big chance that we will need to repeat this vaccine. I don't know if it's going to be once every year, once every 2 years, but right now I think it's at least it seems to be good enough. We need to wait a little longer to say that for definite, but that's what it seems like. So that's really good. What was the second question?
Question is that we see it in Israel. People who get vaccinated, there is an assumption that once you get vaccinated, you can't infect other people.
Yeah, so okay, that's another big question. And we'll have to wait and see. Maybe, and I hope that eventually we will understand and we will know that people who get vaccinated, of course, we do know from the Pfizer clinical study that people who got vaccinated will not get a severe infection, and will not get, most of them, 95% will not get at all infected. But the big question is whether, even if you get, you're exposed, the question is maybe still you are infective. Okay, you don't get sick, but maybe you are still infective and you may get other people. We don't know that answer yet. We have to wait and see. I hope that we'll see that it's also effective against infecting others, but we have to wait for that. There's no answer right now.
I will answer Alan Friend, who just sent the question: is our plans for a vaccine passport? Yes, those who get a second vaccine at Sheba will get a green passport. I think this was brought up. They will get a green passport. The first vaccine, Professor Ayal Leshem was brilliant in making sure that people got a yellow passport from the WHO after the first vaccine, which is stamped COVID-19 vaccine, which he can use to travel. And the green passport will make sure that you will be doubly sure that you'll be able to travel around the world. And with that, I'll turn that over to Professor Leshem, who actually also has been on the front lines and has some interesting things to say.
Good evening, everyone. I'm going to take you to a different disease that you may have heard of, which is called the flu. And how are flu and COVID-19 going to play this upcoming winter in the interaction between them, and perhaps what we've learned from flu vaccine and other vaccines about what could be expected from COVID-19 vaccine. And I'll start with a picture showing several epidemics that affected us during the 20th century. Certainly the Spanish flu epidemic or pandemic back in 1918 was the largest and most deadly of the three. But we all should remember polio, which during the 50s caused 500,000 cases of death and paralysis every year and was overcome by vaccine. We are on the verge of eradication of polio globally. And we can also remember HIV, which is a virus that no effective vaccine was found, and the way to overcome this pandemic was through treatment. So there's certainly a lot to learn, but definitely vaccines are very effective in stopping pandemics. Now, honing on flu, there have been several pandemics during the 20th century. The deadliest was the one that's portrayed in orange, the 1918 Spanish flu, But since 1957 and then 1968, there was the Asian flu and then the Hong Kong flu and other types of H1N1 influenza, similar to the Spanish flu, have circulated the world during the years 77, and then the current strain, which has been around since 2009, H1N1 swine flu pandemic. So influenza, once it emerges, once a new strain emerges, it tends to cause a pandemic and stay around for several years. And these are the ones we direct our immunizations against. A very common confusion is between influenza symptoms and cold symptoms. And we need to remember influenza is not a simple cold. While a cold is a rather mild disease that starts gradually and causes mild upper respiratory symptoms, some rhinorrhea and sometimes a cough, influenza is a severe disease. When you get the flu, you feel it. You get a sharp increase in your temperature, often chills, myalgia, severe headache, and cough and chest discomfort are very common among flu patients. Now, looking at the epidemiology of influenza, we need to remember that the common figures say that about 20 to 30% of children get infected every flu season, and 5 to 10% of adults get infected with influenza. That translates globally to 1 billion cases of every year of influenza. Of those, 3 to 5 million severe cases and 300,000 to 600,000 deaths every year from influenza. And when looking at the clinical severity, we often describe a pyramid of clinical severity, with death being the lowest proportion of affected. Now, if we look at the United States, for example, and this figure was taken from the CDC, estimating flu burden by season during the last 10 years, we see that every year there are about 200 or 300,000 to 800,000 severe cases of influenza, hospitalizations, and several tens of thousands of deaths. So certainly a severe disease that happens every year. However, luckily with influenza, we have a vaccine, and currently we have several types of vaccines with different specifications. New vaccines are entering into commercial, getting approved by the FDA and getting into the market, which are targeting special populations and improved vaccines that have higher efficacy. Now, when you look at who has indications for flu vaccine, you see a long list with children and older adults above 55 years, pregnant women, people with chronic illness, and people that are hospitalized, and of course, healthcare workers, which practically leaves only very healthy people between age 5 and 55. And even these people, when they have a chance, should probably get a flu vaccine. I often get questions about flu vaccines, and one of the most common questions is that flu vaccine efficacy is always described as somewhere between 30 to 60%. And the way to read these figures is really that no vaccine is 100% effective, but if there's a very common disease and you reduce your risk of getting severe disease by 30 to 50%, it's well worth it. And these are based on studies that look at clinical flu. But moreover, the previous effectiveness is in preventing flu. We need to remember that flu vaccine prevents many other diseases. For example, heart attacks, strokes, and death. So for example, this analysis of many studies, which is called meta-analysis, they pull together studies of thousands of people, shows that when comparing people that get flu vaccines, those that didn't get a flu vaccine were at higher risk for heart attack. So doesn't really sound reasonable. How can a flu vaccine be as effective as a cardiac catheterization or a statin in preventing heart attacks? But it prevents heart attacks because the flu is a risk factor for developing a heart attack or a stroke. So a flu vaccine will prevent heart attacks in the population and be effective. So going into COVID, we're all familiar with the story of the wet market happening a year ago in Wuhan, and how this caused first the epidemic in Wuhan and then the pandemic. And we're all familiar with the figures globally today, which Professor Regev well described, and in the figures of Israel, where we're seeing our third wave. And the question is, how is this winter going to play out? And the big answer is, of course, the vaccine. We have a vaccine that's 95% efficacious in clinical studies in preventing clinical disease. We don't know if it prevents becoming infected. We don't know if it prevents you from infecting other people, but we know it prevents a clinical disease. If you got a vaccine and get exposed, you will not develop a clinical illness. And I think the most interesting slide is describes our lesson from another vaccine that prevents a clinical disease, a severe clinical disease in a risk population. And this vaccine is called the rotavirus vaccine. It's a vaccine that's given to children to prevent diarrhea that causes hospitalization. And the similarities are, this is a viral illness, very common. The risk population is well defined. For rotavirus, it's children under 5. For coronavirus, it's adults over 60 and people with risk factors. And it's highly effective in preventing the severe disease. So a rotavirus vaccine will prevent the child from getting severe diarrhea and being hospitalized, but will not prevent the child from being infected. So rotavirus exists in the community and infects children, but they just don't get a severe disease. And what this graph shows is from a study in JAMA that we published when I was at the CDC back in 2015, and it showed the impact of rotavirus vaccine on diarrhea hospitalizations in children. Now, rotavirus vaccines were implemented in the United States in 2006, and if you look at the dotted line, which is the number of hospitalizations per 10,000 American children, you will see how within 2 years, the number of hospitalizations completely disappeared. Now, bear in mind, it took several years to get all children under 5 vaccinated for rotavirus. So what this really tells us is if COVID vaccine is effective in preventing clinical disease in older people and people with risk factors, it's enough that we get a high proportion of this population vaccinated to substantially reduce the burden of COVID on the healthcare system. So older people may still get infected. We will still have thousands of cases in younger people, and some of them will get a severe disease. But the big burden of coronavirus, which is infection in older people that causes strain on the hospitalization system and overwhelming, will not happen if we vaccinate these 2 million people at risk in Israel within the next 2 months. And this will allow us to go back to living close to normal, even though some may still get infected and some may develop severe disease, most people will be protected. So what can we expect this winter in terms of flu? Niels Bohr, which was a physicist, once said it's very difficult to make an accurate prediction, especially about the future. And obviously this winter is not different. However, we can learn from the Southern Hemisphere, from data from Argentina, Chile, and Paraguay, Uruguay, that while every summer, our Northern Hemisphere summer, they see a peak of disease of influenza, this year they did not experience any influenza. So at least we know it's going to be probably an easy winter in terms of influenza. We're starting to see this data from Israel. What you see in this graph is data from Maccabi Health Services of visits for flu-like illness at the doctor office. And on the green and blue and the black dotted line, we see the multi-year and the 2019 and 2018 data that where influenza-like illness peaked by end of December. And we see in the red line the 2020 line, and we see that nobody comes to the doctor, or nearly nobody comes to the doctor with influenza. So at least with influenza, we're not seeing a lot this year. And again, going back to COVID, the big question is, will we be able to substantially reduce the burden, not of cases, but of severe disease by covering the population at risk, the over 60-year-olds and the people at high-risk groups with the vaccine within the next 6 to 8 weeks, and be able to leave our third lockdown without need for further lockdowns. And with this, I will leave you with the conclusions. And this slide shows my parents on the left, myself in the middle, getting COVID vaccines, and my son, my middle son, getting a flu vaccine earlier this season. And so our conclusions is hopefully vaccines will be able to help us stop this pandemic. It's 8 o'clock sharp here in Tel Aviv, so I can turn the mic back to Steve. Thank you, Steve.
Thank you. We're going to stay on for a few more minutes because we have a few interesting questions that I'd like for some of you to answer. Gilly, you know, there's been a lot of headlines around the world about Israel being #1. So, I mean, how has Israel achieved its ranking as the highest per capita vaccines administered? And what has been Sheba's direct role in this in making Israel #1?
So I think it's really an amazing, and again, as I said, for me, it's one of the most exciting things I've ever seen of how everybody was working together. And immediately at Sheba, we organized a very nice vaccination center, and we increased it to having 3 centers actually. One for the healthcare workers, of course, of Sheba, coming in very in order, having in line, which is, as you know, not very typical to Israelis, and really getting vaccinated one by one. You know, it was amazing. Then we had also sort of like a reach out where we invited other populations, starting from Holocaust survivors, whoever they are, wherever they live, they can come to Sheba, get vaccinated with no line. We have similarly done it to the police services and other, whoever is over 60. Initially, we opened it only to relatives of healthcare workers, so all of us can also be safe at home and meet our parents, etc. And then, of course, only those over the age of 60. And then we opened it further. We just got a notice today that the MOH will not allow us to continue this. We have to stop this and can allow only our healthcare workers to continue. But I think if we're looking at the nationwide picture, it's really an amazing and again, really touching and exciting picture to see how all of the Kupot Cholim, all of the different MOHs have really put a lot of effort together. And the logistic part of this is really very, very complicated, particularly with the Pfizer vaccine. As you know, it needs to be in -80. We have only 5 days to move it, and then only 5 hours from the moment that we take it out of the fridge. Very complicated logistic, but really everybody around just got into, you know, putting things together, and I think it's really amazing. I'm really excited from this, I have to say.
Yes, it was quite a picture to see the lines that were out the door literally at Sheba for a few days, and the workers volunteering to work till 9, 10, 11 o'clock at night. Galia.
Yeah, just want to add to your question is, first of all, I think really in Israel, you know, all the organization of the healthcare system is really something that, you know, every Israeli by law must register to one of the MOH, and they have to be recognized by a healthcare provider. It's something special to Israel. And the second thing is really that Israel secured supply very early in the pandemic. Also, I think this is the second answer. And the third one is really the high compliance. And, you know, I think it's exponential, because when you see that many people are going to want to be vaccinated, so, you know, more people want to be vaccinated. And now when we hear that there is no vaccine anymore, so everybody would like to have it.
Absolutely. But again, let's come back to, we're getting a lot of questions about young people, someone, let's say in their 20s, who married or unmarried, or may want to become, is it safe for someone who is in their 20s to get vaccinated, who might want to get pregnant down the line? I mean, we know that there's still an open book, but I know that we've spoken about this, but what would you say?
Yeah, I'll tell you what, as I said, nobody knows, no data. And as I said before, in UK, they don't vaccinate, in US, they vaccinate. So nobody knows. And I think, you have to see what is the risk of the young people. If she's a nurse, if she is a teacher, then I think she's at high risk, and I really recommend, even if she's pregnant. If she, she is at home all the day, so I think she can wait.
I'll add to this because I'm a little bit more liberal than Galia, I know. And I think I typically recommend whoever is, I think, we saw a few cases of very severe COVID in pregnancy, and all of the, at least—
Only 4 cases in Israel.
Okay,
of severe.
When you see them, you know that it can get bad, and all of the, at least theoretical data, there's no reason to think that it would be dangerous. I mean, we're giving during pregnancy the pertussis vaccine, we're giving the flu vaccine, we're giving vaccines, and this vaccine really seems to be safe. So, if I would be pregnant, or if I would have a daughter, I only have sons, I would recommend her definitely to have a vaccine. I think it's important.
So Galia, Gili, you know what? There's a lot of headlines around the world and a lot of confusion, a lot of disinformation. It seems that the UK has thrown a monkey wrench into the whole equation. Okay, the whole business about is one dose enough and vaccinate as many people as possible with one dose. What do you say about what England is doing and what we need to do in order to get out of this?
Yeah, as I said in my lecture, I'm really against it. First of all, there is no data that one vaccine is enough. As I showed you in the phase 2 study of Pfizer, the neutralized antibody are not high enough. And, and nowadays it's so important that many people will be really covered with the vaccine. So I don't want to change it. And I'm against this 1-dose vaccine.
I'll give an opposite, yeah. so it'll be more.
That's okay. It's okay. I like this.
Not exactly an opposite. I think just that the answer is complicated. I truly understand why the US and the UK are pro this, because I think that giving it to more amount of population and getting maybe only 60 or 70% of them really truly vaccinated is better than having a smaller proportion and they are fully vaccinated. In Israel,
but isn't there a deadline? I mean, when you take the Pfizer, wait, 1 second. All 3 of us need to take the Pfizer second vaccine within the next week or so. Now, is there a deadline for it to be that effective? You said, Gili, that you haven't found antibodies in your amongst yourself after the first vaccine. Actually, I'm supposed to jump into your study to find out if I have any antibodies. So what's the deal here? I mean, is it okay to wait? Is it a Russian roulette to keep waiting till you get a second dose, or is there a real deadline involved?
No, so I'll just finish. I think, again, if you are a country like the UK or the US where you don't have enough vaccine, definitely for the high-risk population, I would go for that. In Israel, the case might be different, because if we have enough vaccines, obviously everybody needs to get 2 doses, no question at all. There's a clinical study, it shows that, no question. But if in Israel the situation, and again, I'm not sure, maybe Galia, you have more information. I don't have any information from the MOH whether currently they have enough doses. I don't know why exactly they stopped the dosing in 1 minute in Sheba, but there is at least a rumor that the next dosing, the next 2 million doses will arrive only at the end of January. And that would mean that right now we would stop vaccinating people. I mean, myself and others will get the second dose, while other people age 60 or more or high risk will not get any vaccine until the end of January. And right now, with this high surge that we have, I think this is more dangerous than giving them the vaccine and giving us a little bit postponed the second dose. So most of the people will probably be vaccinated by then. And again, I can tell you that from only the 5 people that I've been looking at this morning of who got the vaccine, me and another person do not have antibodies, but 4 other people who tested today are positive already after 2 weeks, not 3 weeks. So I assume that also my level will increase. Maybe it will go down. It's not enough. It hasn't been in clinical study. I prefer to get the vaccine after 3 weeks. But if there's really an issue and a problem, maybe it's better that my mother will get the vaccine already now, and I will postpone mine for another 2-3 weeks until whenever the vaccine will arrive. So that's sort of how I see it.
No, I don't agree, because I'm afraid that you will not be vaccinated, and all the other that will get one vaccine. And that's a problem. And now in Israel, there is vaccine. However, the Kupot Cholim, or the Ministry of Health, decided, that only Kupot Cholim will vaccinate the people and not in hospitals. So that's the problem.
But why? Why did they?
Because they want the Kupot Cholim to vaccinate and not in hospitals. Because the hospitals, vaccinate, people that are not, should not be vaccinated, maybe later, but not now. So we have enough, but also if you won't have enough, I think that according to the, the protocol, 2 vaccines are effective. We've seen that there are not enough neutralizing antibody. You see that people who are vaccinated 2 weeks ago develop disease, and we see it now also in our hospital. So I want, that people who took one vaccine will finish the vaccines.
All right. Thank you very much, everybody, for joining us tonight, tomorrow, or yesterday. And we appreciate all the input from all 3 of our experts who really have, as you can see, are putting in overtime. Some of them are still sitting in their offices. And we hope that this webinar was informative for you. Yoel, you want to sign off for us tonight?
Yes, I want to thank you, Steve. I want to thank Galia, Gili, and Eyal for leading this beautiful conversation. I want to thank our audience and participants all over the world. For my humble opinion, we have still long road to go. We just crossed the 1 million Israelis, and we still have a long way until the overall population will be vaccinated. Meanwhile, we want to wish you Happy New Year, stay safe, and go get your vaccine as soon as you can. Toda rabba, and goodbye for everyone.
Bye.